Hi everyone, I'm Claisse and I'm going to present our paper titled Understanding Antenatal Care Needs through Co-Creation with Roma Women to Inform the Design of Mobile Health Technologies. So this paper was co-authored with my colleagues Abigail Durrant and Mabel at Newcastle University. So first, let me introduce our research context. Antenatal care services are the care women and people receive whilst pregnant. In the UK, antenatal care services are provided by the National Health Service, the NHS, to all residents. It is usually delivered by a general practitioner and a midwife. Most recently, there has been a trend for the digitization of antenatal care services through mobile health technologies. So for instance, the NHS here has launched its own mobile app for supporting information sharing during the pregnancy. Health inequalities and social injustice in healthcare are well evidenced in the UK. People from minority ethnic groups and those from lower socioeconomic backgrounds have reported poorer health outcomes and experiences of antenatal care. This is particularly true for migrant women in countries like the UK who suffer structural and institutional barriers to antenatal care. So for instance, care pathways and communications with healthcare professionals in a new host country may be complex and confusing for migrant communities. So we work with women from the Roma communities, and here it is important to highlight how the Roma community is culturally rich and diverse, with many subgroups that have distinctive characteristics and identities. In the UK, government-led strategies have been developed to tackle health inequalities faced by this group. The Roma community here is categorized within the GRT group, which stands for Gypsies, Roma and Travellers, which has been recognized as the most disadvantaged group in British society, experiencing significant barriers due to cultural norms, discrimination and lack of familiarities within the healthcare system. Therefore, the Roma community provides us with a complex socio-medical context for exploring how to better support the antenatal care needs of ethnically marginalised women. So let's move on to what we did. So we engaged 11 Roma women from Czech Republic or Slovakia who have settled in the north of England. We organized 8 workshops and a debrief session to understand their pregnancy experience and identify their needs. Through the workshops, we also wanted to understand women's experiences and views of digital technologies to support the pregnancy journey. And this is timely because of the digitization of health services, which is arguably creating a digital divide. So with our work, we contribute to recent call in HCIs for more participatory and inclusive work with women from marginalized groups in high-income countries, to develop richer and more nuanced understanding of women's experiences from marginalized groups. And the aspiration here is to move from a one-size-fits-all approach to a more holistic and intersectional perspective of women's health. The need of women from migrant communities should also be better understood and celebrated through intersectional approaches. So we report new qualitative insights and design implications, contributing to HCI discourses in digital health, intersectional HCI, and women-centered design. We unpack our contribution and previous HCI work in the paper, but for the purpose of this presentation, I will now move on to describe what we did. So co-creation was at the heart of our approach and scaffolded by design-based methods. For instance, we use character-driven scenarios. A fictional character was created, which participants named Matilda. Matilda's narrative evolved through the workshop and was used to prompt conversation during the session with the woman. We also used the pregnancy journey map for women to collectively make sense of the pregnancy journey and represent key moments. Zine-making was used as a method to synthesize participants' contributions to the workshop and highlight key messages the women wanted to share with other women in their community. So for instance, women chose to include messages about dealing with anxiety or emotional well-being during their pregnancy. And this was all included in a co-created printed zine, which was distributed to the wider community for feedback. Next, I'm going to highlight some insights from our reflexive thematic analysis of the workshop, and then I'll share some overall reflection on our co-creation approach. So first, participants highlighted differences in the way antenatal care services were provided in the UK in comparison to their home country. They also reported discriminations and assumptions from doctors and communication challenges at the consultation. One of the women at the workshop said, "The workshop just made me realize some things that, for example, I was mistreated in my first pregnancy." So women also spoke about trauma and mental health issues which they experienced during their pregnancy. Then they highlighted the difficulty of sharing about mental health within their family and wider community. The women were keen for this to change. And so at our debrief session, a participant reflected, "I was very surprised with this project that everybody opened up about their mental health. It was not taboo, which in our community it's a big taboo. But everybody was so supportive of each other, and every woman of different ages in the group we had said it's important to talk about mental health." So the woman highlighted other challenges and the importance of self-care, which were intrinsically linked to mental well-being. And here, in the context of diet management, one of the women highlights the myth of eating for two and how putting on weight during pregnancy can lead to depression after birth. So in the paper, we identify some design consideration, and I will highlight a couple here, and more can be found in the paper. So our participant reported that they did not have any family support in some cases around them, or they were also uncomfortable asking family or friends about their pregnancy. And so as a result, they relied a lot on internet and more specifically on Google for seeking information. But they had many challenges in finding, evaluating, and translating information. And so we discussed at the session the potential of mobile application and online platforms for supporting information seeking during pregnancy, but current design solutions are limited, and previous research reported the lack of trust and reliability of online information and digital tools. So, based on our findings, we highlight a need for creating culturally sensitive content and addressing language and health literacy barriers to minimize digital exclusion. So when reviewing pregnancy apps in one of the sessions, women reported privacy and security concerns for sharing intimate and personal data about themselves and their pregnancy. And here it is important to highlight that people from the Roma community often experience racial stereotyping and stigma, and our participants were fearful of being discriminated because of self-describing as Roma. Some of our participants also describe a sense of responsibility when sharing information via an app, as the shared information was not only about themselves, but also about the baby and wider family, which they felt protective of. And finally, when they reviewed app features, there were also mixed feelings towards having a shared features with partners. And overall, our participants wanted to keep control over what they would share with their partners. So based on our findings, we think that future research should focus on designing platforms or systems that address the complex identity and representation needs of women from migrant communities. And it should further investigate the impact that both public and self-stigma have on data sharing. We should also consider a family-centered approach to design for different sharing preferences that enable women to retain agency and control over shared data about themselves and their family. So in the paper, we share more detail about our co-creation process and some lessons learned, which we hope can be helpful for other SIGCHI researchers working in this space. And I'm just going to highlight some of those lessons learned that we share in the paper. So first, to engage the community through a gatekeeper. So in our case, we use existing trusted network to recruit participants in the community. And it was important to provide our gatekeeper opportunities for research involvement through peer researcher training and mentoring. Then co-creation in a trusted space. So this was afforded by different aspects in our case. So for instance, having a space that is familiar to participants and child-friendly, but also providing food, breakfast in our case, and agreeing on ground rules for participations was critical. We also had to be very flexible with our work plan to address our participant needs, so for example related to childcare. And finally, we made sure that co-creation was embedded throughout our process through using creative and participatory methods and providing participants with opportunity to take part in dissemination activity. So to conclude, there are limitations to our work, but we hope the paper provides a case studies of working towards best practice for research co-productions with marginalized communities. And so overall, we found that the workshop encouraged peer sharing and learning. And so I will close with the following quotes from one of our participants. She says, "I learned a lot of information, not for me because I won't get pregnant again, but for my kids. I will support them to have more information so I can help them pass it the information that I get in here in the workshop." So thank you for listening, and please don't hesitate to get in touch if you have any questions. Thank you.